Hello, everybody, and welcome to today's webinar. My name is Olga Bodie, and I'm a parent and a part of the team here at SYNGAP Research Fund. Our presentation today is a data-driven approach to reconstructing disease trajectories in SYNGAP1 related disorders. I have the pleasure to introduce today's speaker, Dr. Gillian McKee. Dr. McKee is an epilepsy and neurogenetics fellow in the Division of Neurology at the Children's Hospital of Philadelphia. She attended McGill University for her undergraduate studies and completed medical school and earned a PhD in computational neuroscience at the University of Chicago, employing machine learning techniques to understand the neural underpinnings of visual learning and decision-making. Dr. McKee then moved to Philadelphia, where she completed pediatrics and neurology residencies, as well as fellowships in epilepsy and neurogenetics at the Children's Hospital of Philadelphia. Her research focuses on using multi-omics and electronic medical data to understand disease trajectories in genetic epilepsies, including SYNGAP1 related disorders, and employing machine learning techniques for outcome prediction and the development of targeted therapeutics. A recorded version of this webinar will be available on the SRF website under webinars on the family menu. And by the end of the presentation, you will have the opportunity to have your questions answered. We'd love to hear from you, so please write those questions in the Q&A below. For those of you just joining us, again, our speaker today is Dr. Gillian McKee. Her presentation is a data-driven approach to reconstructing disease trajectories in SYNGAP1 related disorders. It's now my pleasure to turn things over to Dr. McKee.
Thank you so much, Olga, and thank you, Mike, and the rest of the SYNGAP Research Fund for inviting me here to speak today. I'm really excited to share what we've been working on at CHOP, using large-scale data to help understand the disease trajectories in SYNGAP1 related disorders. So just to start off, I'm just going to go through a brief outline of my talk today. So first, we're just going to review briefly the current state of SYNGAP research, including what's known about both the clinical disease trajectories and the variant spectrum. Next, I'm going to provide a very brief overview of phenotypic science to orient you to the rest of the analyses I will be sharing later in the talk. And then finally, what we're going to spend most of our time on today is talking about how we can leverage real-world data from multiple different sources, different sample sizes, different levels of granularity, to help delineate disease trajectories in SYNGAP1 related disorders. So to start off, let's review what we all know now. So as most of you are already aware, the SYNGAP1 gene was first discovered actually quite a long time ago in genetics land, I guess, in 2009. And it's among the most common genetic developmental and epileptic encephalopathies. It tends to be characterized most significantly by developmental delay and intellectual disability, autism, and then generalized seizures. And it's actually one of the few monogenic causes of generalized epilepsy, including a specific epilepsy syndrome called myoclonic astatic epilepsy, also known as MAE or DOSA syndrome. So despite significant research interest, one problem has been trying to identify genotype-phenotype correlations. These still remain elusive in SYNGAP, and we'll talk a little bit about why that could be. So I'm not intending this to be a comprehensive literature review by any means, but rather just want to broadly review a little bit what's out there in the existing scientific literature. So this 2019 study by Vlaskamp and colleagues described the phenotypic spectrum in 57 individuals with SYNGAP1 related disorders. They looked in depth at the epilepsy phenotypes in particular, showing that generalized seizures, especially epilepsy with eyelid myoclonia and epilepsy with myoclonic atonic seizures, were most common. And they also did a really, really nice job looking at comorbidities, showing not only the most universally recognized intellectual disability, but also really highlighting some of the behavioral issues that I know many individuals with SYNGAP struggle with. So in addition to generalized description of clinical features, we naturally want to know how the specific change, the specific genetic change in an individual's SYNGAP gene affects their disease course. And that has been difficult in SYNGAP. And this 2016 study tried to address this question and found that in a small cohort of 17 individuals, those with variants in exons 4 and 5 had seizures that tended to respond better to seizure medications, while those with variants in exons 8 to 15 tended to have more drug-resistant seizures. And while this is a promising start, there unfortunately hasn't been that much further data to support strong genotype-phenotype correlations to date. So as you can see here in this figure from a recent blog post by one of our genetic counselors, Natalie, changes in the SYNGAP gene are very broad. They range from single amino acid substitutions to what we call protein truncating variants that just stop the protein early, to whole exon, multi-exon, and multi-gene deletions. And while we know that the overall mechanism of disease is loss of function, or what we call haploinsufficiency, meaning one copy of the gene is not working, teasing apart the specific genotype-phenotype correlations can be difficult. So given that background, here are the specific research goals that I want to discuss with you guys today. So our first goal is to use phenotypic science and data integration from multiple different sources to help us better understand disease histories over time. We want to identify features that are unique to SYNGAP1 compared to other pediatric epilepsies and other genetic epilepsies. We want to try to explore those genotype-phenotype correlations. And then we want to get a sense of caregiver perspectives through disease concept models. And then finally going to talk a little bit about natural history studies and how we can incorporate rigorous questionnaires, clinical scales, physical exams, and even quantitative EEG to get even more fine detailed data about how SYNGAP1 clinical features vary over time. So first, let's talk a little bit about phenotypic science. If my slide will progress, there we go. So my research mentor, Ingo Helbig, loves to display this slide towards the beginning of his talks, just to convey the immensity of data we're able to access through electronic medical records. So this plot shows over 1 million neurology notes for over 100,000 individuals, capturing over 120,000 patient years. So the scale of this data is truly incredible. But because it's so large, it necessitates rigorous methods for transforming and analyzing the data. So this is where we start to get into data harmonization and ontologies. There are many different approaches to phenotyping. And I'm just going to say right off the bat that none of these are perfect. It's always a constant trade-off between sample size and data granularity. We obviously want to maximize both and be up here with the largest possible sample size, with the most fine detailed information we can possibly obtain. But those approaches just aren't feasible, at least not currently. And then methods with very small sample sizes and not very detailed information are not useful. So we're left with approaches that fall along this diagonal line here. So large-scale phenotyping, such as in this neighborhood analysis, uses very large sample sizes, but lacks the granular detail. And then in contrast, you have natural history studies, which record data about individuals at the highest level of detail, but as such can only handle small sample sizes. So it's a constant trade-off. So which method is best? And I'm hoping to convince you today that by using real-world data that spans this spectrum, we can get the best of both worlds to some degree. So let's pivot and look at our sources of real-world data and how they compare in terms of both the sample size and the level of detail. So today I'm going to show you analysis using data from 3 different sources that's kind of run the gamut spanning the spectrum. So first, we're going to talk a bit about some insurance claims data. that we've been analyzing in collaboration with the team at Ambit. They have a very large sample size, but because it's based on insurance claims, it lacks the same level of detail. In the middle, there is Citizen, consisting of curated medical record data with a moderately large sample size and level of detail. And then finally, there's our internal CHOP cohort, where we have access to very, very detailed medical records, but our numbers are comparatively very small. So we've been collaborating with Ambit, which is a company whose goal is to provide solutions to help identify patients with rare disease and to help facilitate clinical trials and disseminate improved therapies. So they do this by identifying patients from large insurance claims database. And as they use a large claims database for their analyses, they have access to de-identified patient data on 582 individuals with SYNGAP. So I just want to briefly credit some of our collaborators at Ambit, Rob, Akash, and Chen. They've been helping us put together some of the SYNGAP1 analyses that I'll be sharing today. So I just want to give them a brief shout out. And then before moving on to our next data source, I just wanted to take 1 second to put in a plug for ICD-10 codes for rare diseases. We're only able to do these insurance claim analyses because SYNGAP has an ICD-10 code. Some of our other rare neurodevelopmental disorders, including STX-BP1, SCN2A, SCN8A, they don't yet have ICD-10 codes. So we're very fortunate working on SYNGAP to have the ability to use this claims data set due to the advocacy of the SYNGAP community. So our next source of real-world data is likely familiar to most of you or many of you on this call, as Mike and the Syngap Research Fund have been one of their more vocal cheerleaders, and that's Citizen. As you may know, they aggregate data from medical records and provide it to researchers, physicians, pharmaceutical companies with the goal of advancing targeted therapies for rare disease. And here I'm just showing you some of their partners, including, of course, the Syngap Research Fund. And then finally, at CHOP, we follow a comparatively small cohort of SYNGAP1 patients through our epilepsy neurogenetics initiative. And on this cohort, we have access to detailed clinical histories, medication prescriptions, lab work, imaging, EEG results, all the information that's gathered through our routine clinical care of these patients. So by harmonizing these 3 sources of data, we're able to generate a more complete view of the clinical histories of our patients over time. So just a quick reminder about the 3 cohorts and where they fit in. So Ambit, this is the claims data set using the ICD-10 code, and they have a total of 582 patients with SYNGAP. Most of the analyses I'm going to show you are focusing on a smaller subset of these, just to focus more on pediatrics. Then Citizen, the data set that's included in the analyses I'm going to show you has 150 patients, but they now, I've heard, have over 200 enrolled. And this is curated EMR data. And then finally, our local CHOP cohort, where we have about 30 patients with SYNGAP, where we have information in our local electronic medical record. Some of them obviously are followed more longitudinally and we have more detailed data than others, but it tends to be more extensive detailed data than the other 2 resources. So here is an overall characterization of our combined CHOP and Citizen cohorts. The figure on the left here is showing time-stamped data points for each individual plotted against the individual's age at the time that data was acquired. So we definitely have more data on younger patients. As you can see, the points tend to cluster on this side of the plot. But we do have some individuals with data through their teenage years. And then here on the right, you can just see a summary table showing the clinical features of this combined group. So as I just mentioned, they tend to be young with a median age of 6.7 years. And then hearkening back to the variant spectrum, Most individuals tend to have protein truncating variants. So those are the variants that either introduce a stop codon too early or a frame shift and then a stop, and it just cuts the protein short and it's just degraded and there's no protein. While only 13% have missense variants in SYNGAP in this cohort. And the epilepsy phenotype in SYNGAP is quite unique. Individuals have generalized seizures, with 27% having absence or those staring seizures, 23% having myoclonic or those quick body jerk seizures, and 30% having atonic or drop seizures. And many children, as I mentioned before, with SYNGAP are diagnosed with that specific epilepsy syndrome called myoclonic atonic epilepsy or DOSA syndrome. And there's actually only 2 other monogenic epilepsies associated with this syndrome, and those are SLC6A1 and Neck-Smith. So the most commonly reported clinical feature is developmental delay or intellectual disability, and that's present in 97% of this cohort. Other very common features include hypotonia and autism. And finally, something that is somewhat unique to SYNGAP is behavioral concerns are very, very common. They're reported in 93% of individuals, and especially aggression, attentional concerns, including ADHD, and then problems with sleep are also very, very common. So now what can we do if we look at the broader population that's captured by claims data? So since the introduction of the ICD-10 code in 2021, AMBIT has been able to identify 582 individuals with SYNGAP. And for most of the analyses I'm going to show here, we restricted those to under age 20, so that includes 236 individuals. We did this to facilitate the comparisons across our data resources because most of our other sources only have younger patients. But we don't want to ignore the older population. I think it's actually really great that AMBIT has so much information on adults with SYNGAP. And this is definitely going to be an interesting group to characterize more thoroughly because we don't know. We don't have a lot of information on what do people with SYNGAP look like when they are 30 or 60. So I do think don't want to ignore this population. We're just limiting ourselves to under 20 for now. So here on the left, you can see the monthly number of new patients with the ICD-10 code-based diagnosis. And then the cumulative number is shown here in overlay. And then on the right, I'm showing you a similar plot to the one I showed you for the CHOP and citizen data, with each horizontal line representing one individual with start and stop points corresponding to the ages for which they have data in the claims database. And you'll notice that the width of most of these bars is a maximum of 6 years, and that's due to this database only having 6 years of data. But so while we're already with this data, as I'm going to show you, able to learn new insights, this is a resource that's only going to get more and more useful over time. Now that we have the ICD-10 code, more patients are going to be their prescriptions, their clinical features are going to be coded with that diagnosis, and we'll be able to pull all of that data in the future. So flipping back to citizen for a second, one really great aspect of the citizen data set is the developmental milestones. So here you can see for all individuals that attain a given skill, shown here, the cumulative percent of people who have achieved that skill by a given age. And the dashed vertical lines here represent the age at which 90% of people who ultimately attain that skill have reached that point. So for example, 90% of patients who ultimately walk unassisted, so this dark purple line, have achieved that skill by age 3. So once we've extracted and harmonized all this data, we can start to ask questions, such as how does the prevalence of certain clinical features change across the lifespan? So here I'm showing you the presence in red and the absence in blue of 4 features that are commonly associated with SYNGAP and how those change over time. So compared to just a static proportion of individuals, adding the dimension of time really gives us a better sense of what to expect over the course of a child's lifetime. For example, you can see that while most individuals have seizures during their lifetime, actually very few people have seizures in the first 2 years of life. And you can see that here, these bars are all blue for the first few time bins. And then in contrast, hypotonia is very, very common early in life, but becomes less noticeable or just less documented over the course of someone's lifespan. So in addition to looking broadly at just the presence or absence of seizures, we can grade the severity of seizures over time in monthly time bins to get a picture of the dynamic nature of seizures in SYNGAP. So here you can see the proportion of individuals with different seizure severities coded by color over the first 5 years of life. So we break this down into 6 different categories: seizure-free, monthly seizures, weekly seizures, daily seizures, several seizures per day, and many per day. And then for each monthly time bin, we show the proportion of patients which falls into each of those categories. And then it's probably kind of hard to see for you guys on the computer screens, but between each bar, there's little connectors, and blue connectors mean that someone's seizure frequency went down, so it improved, and yellow connectors mean their seizure frequency went up, so it got worse. And one unique thing about SYNGAP compared to many other developmental and epileptic encephalopathies is that seizures tend to start a little later. So you can see here, usually in the 2nd or 3rd year of life. And here you can see a direct comparison of SYNGAP to some of our other common genetic epilepsies. And it's really striking how different the seizure trajectory is in SYNGAP compared to these other causes. Like STXBP1, SCN2A, SCN8A all have really significant proportions of infantile onset seizures, whereas in SYNGAP, that's really absent. So far, we've looked at milestones and how phenotypes change over time, but what about medications? Using our prescription data extracted from our local medical record and then combining this with what's available on medication data within Citizen, we can look at the medication use over time for both anti-seizure medications and then medications that are used for behavioral purposes, such as sleep, attention, or aggression. So for seizures, what you see here kind of confirms my clinical intuition. There's a lot of Keppra, you can see here levetiracetam, there's a good amount of valproate or Depakote being used, and Omfi or clobazam, but it's a little bit all over the place. And then, followed a little later by more lamotrigine. And then for behavior, it seems to be dominated by sleep aids early on, a lot of melatonin, and then you only start to see antipsychotics like Risperdal appearing later once these behaviors become harder to control. So when you ask the same question using claims data, the answer looks a little different. I'm showing you right here the same, this is the same CHOP Citizen figure on the left, and then an equivalent one generated by claims data by Ambit on the right. And while there's still a lot of Depakote here, you see a lot of Onfi up here, that's a CLB is Onfi, and Lamictal here in the middle, LTG. But there's less Keppra. And then you notice zonisamide and Topamax here, which are 2 similar medications that were virtually absent in our data. There's like tiny little slivers of them, become much more prominent. And the exact reasons for this are still unclear. We're going to have to look into it a little more, but it may have to do with differing prescribers and just the overall differences in the populations we're assessing. So one unique thing about the claims data is it's relatively easy to identify comparator groups, which would be very difficult for us with our local EMR to have to manually go through and like reconstruct seizure frequencies for hundreds of children with epilepsy. But with the claims data, it's relatively easy for AMBIT to go and pull a comparator group. So here I'm showing you the same SYNGAP medication landscape on the left from AMBIT, but compared with one that the AMBIT team created for all patients with a diagnosis of Lennox-Gastaut syndrome. And this one's quite remarkable because it incorporates data from over 17,000 individuals, illustrating the power of claims data. But it really also highlights the unique patterns of medication use within SYNGAP. So now that we have detailed seizure reconstructions over time, and we're able to get a sense of medication prescription information over time, we can combine these two into a comparative effectiveness framework to assess which medications may be the most helpful, which is ultimately what people want to know, right? Which medication should we prescribe for this child? So much of this work has been done by Julie, who's a data scientist in our lab. So at the top here, I'm showing you a schematic example of seizure frequency over time in just one individual. And then on the bottom are the prescription dates and periods of use for different medications. So highlighted in green are periods of seizure reduction, so times when the seizure frequency drops, so here and here. And then highlighted in blue are periods of maintained seizure freedom. So using this data, we can compute odds ratios of the effectiveness of either reducing seizure frequency using the medications that they're on during those green periods, and maintaining seizure freedom by using the data from the periods of those blue periods where they're seizure free. And I'm showing you both of these in blue, B and C. So B are the odds ratios for common seizure medications for reducing seizure frequency, and in C is for maintaining seizure freedom. And what we see is that Depakote seems to be the most effective for both reducing seizure frequency and maintaining seizure freedom, while Lamictal is effective at maintaining seizure freedom. And this will improve as we have bigger sample sizes, but most of these other medications, their confidence interval crosses 1, so they haven't reached significance. But there are other medications on this list that may be promising as well. So now taking a step back and going back towards phenotyping with claims data, we can take advantage of the fact that the database doesn't just include patients with SYNGAP or genetic epilepsies to help us further define the characteristics unique to SYNGAP. So here we're comparing the frequencies of different clinical features within individuals with SYNGAP, here on the y-axis, to all individuals with a G40 plus ICD-10 code diagnosis. So what that means is that's just a broad group incorporating all different seizure and epilepsy codes. So here the red dots represent significant associations. So as you can see, there's very many, and we've just labeled a few. And they're the ones that we would expect, like intellectual disability, autism, behavioral abnormalities and hypotonia are increased in frequency. They're like, you could say, enriched in the SYNGAP population. But this is just a preliminary analysis, and we have many more of these red dots that we have to look into and explore to try and see if we can identify other unique features of SYNGAP that maybe haven't previously been identified. And in addition to using this analysis method to compare SYNGAP to other types of epilepsy, we can make comparisons within our SYNGAP population to try to assess for any genotype-phenotype correlations. So here I'm showing the frequency of clinical features in individuals with protein truncating variants compared to those with missense variants. And in this preliminary analysis, there seems to be an enrichment of ataxia, tremor, and atypical absence seizures in those with protein truncating variants compared to those with missense variants. So as I've alluded to before, one difficulty in identifying these genotype-phenotype correlations is that the majority of the pathogenic variants are protein truncating. There are, however, many missense variants that are classified as VUSs, meaning variants of uncertain significance. And some of these individuals likely have SYNGAP, but they may not receive a diagnosis. So this can hinder both their clinical care and ongoing research efforts. So one thing we're just starting to work on, and I'm just going to share a little bit with you guys, is trying to see if we can build a predictor to predict whether a certain variant of uncertain significance is pathogenic or not. And this effort is still in its infancy, but what we have done so far is we're looking at several of the existing scores that are used to predict the harmfulness of a variant. And here we've got the scores plotted for, sorry, it's kind of hard to see, for in red, pathogenic and likely pathogenic variants, in blue, benign and likely benign variants, and then in gray is all of the VUSs. And what we can see, at least preliminarily, is that the Ravel score seems to get the best separation between the benign and pathogenic variants. But this is just a teaser, and stay tuned because we're going to be working on this more. So I've been talking a lot about how to use data to reconstruct longitudinal phenotypes, which will be important for future clinical trial design. But one important aspect that's been missing is the lived experience of individuals and their families. And any trial that's worth anything needs to consider these factors when creating outcome measures. So here's where we enter the disease concept model. These are formal frameworks designed to assess this lived experience of individuals and their families. So this is an incredible project by our own Katie Rose Sullivan. She's a genetic counselor with Engine and a member of the Helbig Lab. And she conducted semi-structured qualitative interviews with 19 caregivers of 16 different individuals with STX-BP1 related disorders and 7 healthcare professionals. She then systematically coded them using in vivo software and then grouped concepts into the domains of symptoms, symptom impact, and caregiver impact. And here is just one of her beautiful figures. Here you can see the frequency of these symptoms, symptom impacts, and then caregiver impacts over time. And it's really a beautiful and systematic way to identify things like the effect of symptoms on work or the emotional the emotional toll on caregivers that previously hasn't really been studied or identified in such a rigorous way. So there are a lot of interesting findings in her study, but one I just wanted to highlight is this figure illustrating the differences in the emphasis placed by healthcare providers and caregivers on different symptoms. For example, providers were less likely to mention things like socialization, sleep, and schooling than the caregivers were. And as a clinician caring for children with rare genetic epilepsies, this is something that I really am trying to keep in mind, because the things that are important to us and we think of going through a visit aren't really what's important to families a lot of the time. So I think this is a really important study to kind of get that point across. And while Katie Rose's work was with the STX-BP1 community, I'm very excited that we have Sydney Stewart, a genetic counseling student and a former genetic counseling assistant with our program, who's going to be working on this for SYNGAP. So hopefully we'll have something to share soon about how this is going. So finally, I want to briefly talk a bit about natural history studies, as we'll be starting one soon here at CHOP. As many of you are likely aware, CHOP and Penn received recently a $25 million gift to establish ENDD, which is the Center for Epilepsy and Neurodevelopmental Disorders. ENDD will be led by Ben Prosser, whom many of you know is a Penn researcher, but also an STX-BP1 parent to Lucy. You can see Lucy here. and co-directors Bev Davidson and Ingo Helbig at CHOP. So the goal of this project is to accelerate research and therapies for rare neurodevelopmental disorders. And part of this gift will be going to fund a CHOP-based natural history studies for both STX-BP1 and SYNGAP. So this is very excited. So I just want to share a little bit about the content and structure of this new study. So here's just an overview of our ENDD clinical team. We have neurologists, developmental pediatricians, a few genetic counselors, nurse practitioner, we have physical therapy, we have occupational therapy. We're also going to include patient and family engagement, clinical research coordinators, genetic counseling assistants, and other trainees such as residents and fellows. So a large team with broad areas of expertise. And then we are in the process of finalizing the specifics for the natural history study, but I just want to share with you guys a brief overview of what we have planned. And this is the STX-BP1 specific plan and timeline. We're still developing the SYNGAP specific one, but it will follow a similar format, but some of the exact scales and assessments will differ slightly just so we can better capture some of the things that are more unique to SYNGAP, such as some of the behavioral concerns. But what this will consist of is caregiver questionnaires prior to the visit, which you can see here. And then you'll come for detailed visits on site every 6 months. And this will include clinical assessments, standardized developmental scales, and a quantitative EEG as well. So for all the families on the call, if you are at all interested in coming to see us in Philly to participate in our natural history study, please send us an email. We're probably going to have a new email shortly that will be specifically for the natural history study. But for now, you can reach out to us at our epilepsygenetics@chop.edu email. We are starting to open up the schedule for July and schedule patients. And we would be very excited if anyone on this call wanted to come hang out with us. Also, if you are not sure and you just want to learn more and have any questions, definitely please reach out as well. We would be very happy to answer them. And I can also answer any during this call as well. So I went through those much quicker than I had anticipated, but on that note, I just want to thank our collaborators at Ambit and Citizen for all their efforts helping us advance our knowledge of SYNGAP related disorders. And then to conclude, I want to thank Ingo and the rest of the Helbig Lab, and especially CHOP's Team SYNGAP over here. And then also Mike and the rest of the SYNGAP Research Fund. Thank you for inviting me to speak today, and for all you do to help SYNGAP families.
This is awesome. This is awesome. Thank you very much, Dr. McKee. I have a lot to say. Before I say it though, please everybody ask questions. I will be at CHOP on Monday. I have seen how hard it is to get time out of people like Dr. McKee. So this is your moment. Ask questions. Feel free to ask her to go back to slides. I'm expecting questions on meds, but I want to just make a couple of observations while I'm blathering. One, I want to thank Dr. Hans Schlecht, who has been on our board and is part of our leadership team and drove the ICD-10 code work. And I will say is driving the ICD-11 code work, which is not just a rinse repeat, it's a whole other everything. And that is one of the ways in which SRF is a leader, is we had the foresight to get on these things, because as you heard today, and please correct me, Dr. McKee, if I misspeak here, having the ICD code creates opportunities for things like claims databases and Dr. McKee to figure out SYNGAP. So when I tell all of you to please remind your clinician that we have an ICD code and to take the ICD code to your meetings, this is why it matters, number one. Number two, you saw the Citizen data. Sign up for Citizen, it's free, and it results in insights like what drug will we give our kids, because our kids are resistant to drug, and understanding that the DEPA code is one of the most effective while not dismissing all of the side effects, is a really interesting finding. And I'm not a clinician and I don't give medical advice. I will say I've heard a lot of parents say, we started on Depakote, we didn't love it, we weaned it down, and then when we went to no Depakote, seizures came back, and then we went back to a little bit of Depakote, seizures stopped. So there's something there, but me saying that means nothing because I'm just a dad. But when we get data from citizen and claims data, and we get someone like Dr. McKee, who's a doctor, then other doctors listen and our kids get the right drugs, right? This is all about reducing the suffering of our children and accelerating the development of therapies. So when I pound the table about ICD codes and citizen, I'm just overwhelmed with excitement about what we saw today, because you're seeing why this stuff matters. And I'm going to shut up and take questions. The point I just want to observe is that was a masterclass in a webinar. It was beautifully delivered, it was thoughtful, it was measured, the slides were clean. Just an amazing presentation, and thank you. We're really. I'm at a conference right now, and there's 30 people in the next room who have kids that are going to die in a couple of years or are going to spend their life in a home, and they're nowhere near as far as we are. And I'm speaking at this conference, and I am acutely aware that we're really lucky. I mean, our life sucks, and I hate what my son has, and I hate what it's done to our family. But I realize we are so lucky to have people like Dr. McKee and Dr. Helbig and Dr. Ludwig and all the other doctors who are on this webinar, as well as our families. And it's just really hope-inducing to see this presentation. This isn't just data science. This is going to reduce suffering and get us closer. So it matters. And with that, someone please ask a question. I will take families first. Ed is asking about the NHS. How many individuals are we looking for?
So we're starting slow to ramp up. We are initially planning for 2 STX and 1 SYNGAP each week, and it's going to be on Thursdays. But we are willing to schedule out long to accommodate, and then hopefully it'll be 2 and 2 soon, and then we'll see how the demand goes and how our resources go in terms of ramping up.
And you kind of glossed over this, not a criticism, just an observation. We're not signing up for 1 visit. We're signing up for a visit every 6 months for a period of time. Is that right?
Yes. Yes. So the goal is to come every 6 months once you enroll. And we know we're asking a lot of families to participate in this, especially people who aren't local. It involves coming to Philly, staying for probably at least a day, like at least one night, depending on how far away you're coming from. There's caregiver questionnaires we're going to ask you to fill out prior to the visit. It's going to be a full day of assessments, clinical assessments, PTOT, performing different developmental scales, and including quantitative EEG. But we're really, really hopeful and optimistic that the data we get from this will make a difference.
And I'm sure and we don't need to get into this now, but if there's a family who wants to participate and the cost of the travel and the accommodation is a problem, I'm somewhere between CHOP and SRF, cost should never be a barrier to taking part in this. So, please don't if you're out there and you're like, oh, I want to do this, but I can't afford it, don't let that be an issue. Just let us know. That's why the fund is here. JR who is a mom, in the question says, first, what ages will you be seeing in your study? Second, do you think you will have behavior specialists in your team? From ages 8 to 13, my son's behaviors went from cute to overwhelming and destructive. It might help. I want to know, this is a good point, that his behaviors got better as he got older.
That's interesting. Yeah. So in terms of the team question, we are planning to have a developmental pediatrician who is someone who handles behaviors, prescribes behavioral medications, and is kind of our expert on that front. I know every place does it a little bit differently, but behavioral issues at CHOP at least tend to be split between child psychiatry and developmental pediatrics. So that's why we are involving Dr. Kruger in this clinic as well. And then in terms of ages, I may actually have to get back to you guys on that. I believe it's anybody, but I'm not sure if Sarah has joined the call, and if she is, she can text me to tell me if I'm wrong. But otherwise, I can get back to you guys on that.
And I also want to say, because people are going to ask me.
Okay, she just texted me. It's anyone. Anyone.
Okay, good. Awesome. I want to also observe that SRF is working with Sydney and Combined Brain on the disease concept model. We are recruiting. Don't worry. As soon as we get the ideal demographics for that population, Corey and Callie are going to be all over it. So remain calm, people. Yeah, I think behavior, when I saw that slide on the STX one and I looked at the caregiver assessments,
Mm-hmm.
I mean, you know this, behavior is a bigger issue for, I think, for SYNGAP than for STX.
Yeah, it tends to be, from at
Can
least
you go
from my
back? Can you go back to the drug slide?
Yeah.
Citizen and Ambit, please.
Mm-hmm. Where is it? This one, the seizure.
Yeah.
Yeah.
How much should I read into LTG going to 0?
For the Ambit data, you mean?
Mm-hmm.
You know, I don't know. We have to look at this more. I don't think you really should read all that much into it. Yeah, it seems to really just be from like 5 to 15 here that there's a lot of lamotrigine. These are all pretty preliminary. I wouldn't read too much into it. This is just telling you the prescribing practices, not really the effectiveness, right? It's just saying which meds people are on. Hopefully that somewhat corresponds to how effective they are. Hopefully we don't have a ton of people taking medications that aren't working for them. But in the comparative effectiveness analyses, lamotrigine still looks pretty good. So I wouldn't discount it because it goes to 0 here.
Yeah. Cool. Kevin, if you've got a question, go ahead.
Yeah, can you hear me?
Yep.
Yeah.
Okay. Yeah, Jillian, so this is very good, and I'm sold on all this data. It's wonderful. But it seems to me like I just would like you to explain to me or help me understand better what I think is a missing piece of data, which is we go to the doctor regularly with our kids. And so there's lots of great data that you can pull from. But our kids go to school or whatever similar thing they're doing that's not school all day, every day. And, you know, so when I'm thinking about the genotype phenotype correlation and, you know, looking at stuff on this exon or that exon, are we missing crucial data in not asking families what their kid is doing all day and trying to parse if there's a difference there?
You mean in terms of like having teachers assess how they're doing in school?
Well, no, I mean, not an assessment like that. I mean, so the kids who have more language, have they been in a general ed setting with an aide, and the other kids with less language have been at home with ABA? I'm not trying to, I mean, I get that this is kind of a controversial thing. All of us have to figure out what's best for our families, but to the extent that there's not a drug or a treatment today, are the choices that we're making with our kids, you know, is this an appropriate place to be looking at some of that data? That's what I'm curious about.
Yeah, and I mean, we definitely should look at that. That's a very important piece, and we haven't yet. It is always something we counsel, right? When you see patients in clinic, to maximize their development, maximize their therapies. It's a hard balance to strike, as I'm sure everyone on this call knows better than I do, for your family and your life. And hopefully some of this could be captured a little bit in the disease concept model too. But it's definitely a weakness that we don't have more data on this right now.
And I just wonder if you couldn't add a couple of questions. If you're going to be doing all this deep phenotyping and trying to get all this information from families,
Yeah.
would this be something useful? And, you know, I get that the data would be noisy because every school is different, every kid is different. I understand that, but I just think it's an opportunity for more information.
Yeah, during our clinical assessments, we do ask like how much therapy people are getting, what sort of school setting they're in. It's not always recorded in the most standardized way. That probably means it does get missed in some data extraction processes, depending on how you're doing that. But yeah, I think that's a great idea to have a more explicit part in whatever data gathering instrument we're using to really define educational setting, what therapies, hours of therapies, all of those things.
Yeah, I thanks, Kevin. I'm really glad you brought that up. I want to make 3 points. One, I do think IEPs and ABA notes are a huge source of semi-standardized data that we should turn the Helbig McKee machine on, right? A lot of PDFs there some robot could look at. And I think the specific question I have is, how many hours do our kids get written for? At what ages? And then how many hours do they end up using? Because there is such a thing as fatigue. And I'll tell you a story about Tony. When he was 3 and having absences that we were missing, or 2, having absences we were missing, everyone just thought he took after his dad, a little chubby, a little lazy. And so we just therapied the hell out of him, right? And one day he went to preschool, and then he had PT, and then he had ST. And this poor little Syngapian was exhausted, and he's standing there while his nanny's talking to his therapist, talking to his dad, and he had his first convulsive seizure because we had wiped this little boy out. And there's a limit to how much our kids can take sometimes. And I think the guidance, maximize their development and give them a lot of therapies, there is a natural limit of what our kids can take. And I think refining our understanding of the optimal balance between speech, PT, OT, and ABA is probably a topic for another time, but it's something I would be happy to support some research assistant digging into, because there's a trove of data there. And I think, as usual, Kevin's onto something. I want to just call out some of the questions here. These are easy, so I'll let you blow through them. Eric is asking, is there an age limit on the SYNGAP study at CHOP? Emily is asking the real good one here. Will there be additional detail on seizure type versus effective medication, right? As our kids go from the absences to the convulsives, sometimes to the drops, to the meds change. And then Olga is asking a question that I kind of answered in text. Is AMBIT's data all based solely on the ICD-10 code?
Yes, so great questions. If I miss one of them, remind me, Mike. So first, the age, it's anyone for SYNGAP natural history study. Sarah just confirmed. We will see everyone. The next question was specific seizure types. Yes, that is hugely important, right? Especially when you're looking at broader populations, certain seizure types respond in opposite directions to certain medications, right? For now, we have not separated them out, largely due to it's always a trade-off between your sample size. If it gets too small, you lose statistical power. So you just don't have the ability to detect significant changes if you subdivide your groups too small. But once we have more patients, more data, then that's definitely something we should look at once we have the power to do it. And then the last question was AMBIT, ICD-10. So they have to have a way to find SYNGAP patients in claims data. So they use the ICD-10 code to identify the patients and then look at the medications and other clinical data that they have for those patients. But yes, if they're not tagged with an ICD-10 code, then we would be missing those patients.
Awesome. JR, you have so much. Are you sure you don't want to just talk?
Yeah, of course. Thank you, Mike. So when Kevin was talking and then Mike, I wrote a sort of long and winding question. So I'll try to just summarize it. In addition to adding on to what Kevin was asking about, which is, is there some sort of school or other type of other thing where our kids are doing all day? Is there data from there that we can be using? in addition to the things he mentioned, there's also like teachers do a lot of toileting data, behavioral data that you can overlay with when your meds are changing, you know, how many times they try to elope, food issues. And, you know, personally, we all know there's good weeks and bad weeks, but we don't kind of standardize it. We don't really write it down, right? As a family, it's a lot. But schools actually have a huge amount of data. And you know, there's a letter that goes home every time my son's behavioral plan had to be implemented, right? And so I get a letter and they say this happened and this is what we did and we did it according to plan, right? So there's actual data there that can be scraped. And adding on to what Mike said, what did I say? Oh yeah, that was it. So I don't know that. Again, Kevin asked, is this the right place to do this? I don't know that you want to add these dimensions, but you guys are doing this, you know, you seem to have a lot of money and you're starting this. And I think it's really good to think about these ideas and where can you get the data?
Yeah, I think this is actually a really important point, and I'm really glad we're talking about it now. I do think some way to capture how kids do in outside of home situations is because a lot of them spend a good portion of their time there is really important. You mentioned that they already send home data to you, which is great, but I imagine that would be different for every person. Like not every school was going to report the same things. So it becomes like a data standardization problem. But we can talk as a team if there's other, even it would be additional questionnaires to like assess more like teacher perspectives. We do that for the diagnosis of other conditions. Like the one I'm thinking of on the top of my head is like to diagnose ADHD, we have a parent form, like the Vanderbilt scales. You have the parent scale and then you have a teacher scale, and you have to have them filled out from two different situations because the features have to be present in more than one situation, right? And so we definitely take schools' opinions and assessments into consideration at other times in pediatric neurology. So why would we not try to do it here?
I realize a lot, you've got the $25 million as an eye-catching number, and I'm also aware that large chunks of it are going to be sucked up by beautiful labs doing incredible science. If SRF needs to pay for a research assistant to go through everyone's IEPs, you should call us, because I really do think there's a lot of information there. And I, you know, between yourself and Dr. Ludwig and others on this call, I will be correct. I'm happy to be corrected, but I've been in the rare disease space now for 5 years, and I know very few diseases that consistently, I realize a lot of these kids have behaviors, but I don't know another gene where behavior is such a consistent burden on families. I want to call out a question. Actually, while you're on, JR, you asked another question about beautiful slides and impact. Do you want to do that?
Right, yeah, could you, I think it's a few forward from this medication landscape slide. There's one that had sort of square pictures. I just keep going, I'll tell you when we see it. And I didn't understand what the data said, so.
Sure.
And I did understand what you were talking about in a lot of these slides. It's amazing there.
Oh, going back?
Yeah, go back one.
This one?
So yeah, can you explain what the different different colors mean, and what's the 0 to 1 density? Like, yeah, I didn't know what density meant. I guess I understand the age. I don't understand what density means.
Oh, it's just like the proportion of people that reported those symptoms. So
I see. So
it's similar to like the medication landscape as a density. It's just kind of like a proportion.
Okay, so I guess so the top ones are in basically nearly 100%.
So no, it's not so it's a fraction of it's like a piece of the pie. So like the behavior like comes down like this. So it's this. So like early on, maybe okay. Like, what is that?
They're not overlaid. They're not overlaid.
No, they're not.
They're separate.
They're not.
Okay.
And this is STX. This is not SYNGAP1.
STX, yeah.
Right. No, I just didn't even, I didn't even know how to read it though. Okay, great. Yeah. Great. And then can you go to the next slide? Because that one was pretty too.
Yeah, I know these are the beautiful ones. We're gonna do this for SYNGAP. But
So what's this kind of plot called?
oh my gosh, what's the
It's
actual
not a
name?
spider plot, right? A spider
No,
plot's
it's
different.
not.
Radar?
Blanking on the name of
I
it.
call it a radar plot.
Yeah, it kind of looks like a radar light. You can call it whatever you want.
Petals, it's like petals of
But yeah,
different stuff.
it's kind of like a circular histogram, but were you asking what it means or?
Yeah, no, it's a circular histogram. I got it now. Yeah.
Yeah.
And also I'm remembering it's about STXVP1. So,
Right.
okay, thank you so much. And I hope we don't, I hope I don't sound like I want more. I'm so excited about this, and it's really amazing to hear what you're doing and see what you got so far. Thank you very much.
You're welcome.
Yeah, there's a beautiful chat going on. Julie is commenting on the IEPs, and Kevin is observing that another really hard and like incredibly meaningful data point that people get lawyers to argue over is percentage of time in a gen ed versus an inclusive classroom.
Mm.
And again, N of 1, the plural of anecdote is sometimes data. Tony went quickly from 90-10, 80-20 gen ed, inclusive ed to exactly the opposite. And our kids do tend to be cute until they're ferocious. And I get in trouble for saying that because there's parents of 2-year-olds on this call who are like, oh, what did Mike just say? But it's true. And I think we have to be honest that, this disease has a winding path. Anyway, Yulia, if you want to talk, go for it. And then Emily, do you want to ask your question about blood or do you want me to just read? I'll just read it.
This is Emily. Can you hear me?
Yeah.
Sorry, I am picking Hadley up at school, so it's going to be, you might hear her in the background. But I did have a question. I recently had read some articles about blood work being used to identify seizures and epilepsy, and I was wondering if CHOP was involved in that at all, or if that's something that they're familiar with. And then also, if we're tracking any of the physical attributes with the kids. I know we've, as Syngap Group, talked a little bit about some of the similarities that the kids have, but I was wondering if that was something that is part of the research.
Oh, okay. So in terms of like blood, is it like biomarkers of epilepsy? Is that what you're asking about? Because we are.
I didn't get the full
Okay.
details, but there was a recent, can't remember exactly where it was published, but I don't think it was biomarkers. I think it was like a lab test that could be done like at an annual doctor's visit that could detect whether or not a seizure had been registered. And I don't know how that works. And I don't know if it's maybe something I got wrong, but
yeah,
curious.
I'm not sure about that.
Okay.
But we are planning biomarker development as part of one of our future goals. So yeah, I have to look more into the other one. I'm not sure what that would be.
Okay, I can, share it if I find it. Look it up.
Get it? Yeah, awesome. And then Yulia, do you want to say anything? And then I just have one more doozy for Dr. McKee. Oh, I have 2 doozies for Dr. McKee. Okay. Yeah, and then I'll get to you, Ashish. I'm just trying to privilege families first. Doozy 1, because this is the question I get more than anything, right? My kids just started seizing. I went to the doctor. What drug should I ask for? It is the question. And I realize that it's a loaded one, and you're a clinician and they're clinicians, and every clinician's got their favorite cocktail. What would you say, speaking from the data? And then doozy 2, it's related to your bus slide. And the question is, what are your thoughts on PTV versus missense? I can talk about that ad nauseum, but.
Okay. So first medication, new onset seizures. It always depends on like the whole patient, right? The rest of the clinical scenario, but based on the data, I would think Depakote would be a really good choice as a first med. Other combinations I tend to lean to are like Depakote Onfi, Depakote Lamictal. They tend to work. They're sometimes tricky, so a lot of people don't like to use them together, but they tend to work well together. Keto also, we didn't have any, we haven't put any comparative effectiveness of keto, but that's definitely something we're going to look at too. Tends to be effective.
Yeah, let me push you on this. Not push you, but let me just tell you the next question I get after I say what you just said, right? Because I'm very quick to share that Depakote seems to be particularly effective for the drops.
Yeah.
Like if a kid is having drops and not on Depakote, I tell them to go ask for Depakote. But I also tell them, and what I see again and again with SYNGAP kids is the neuro always writes a lot of drug. And something I learned in college was with pretty much any substance, start low and go slow, right? And so I encourage people to consider just ramp up slightly to whatever they started you on. But I'm not a doctor and I don't give medical advice. But with that said, like very few of our kids are successfully treated on one drug. And Depakote specifically, while incredibly effective with SYNGAP, sometimes at the prescribed dose tends to have undesirable side effects.
Yeah.
So what is the most masterful way for a parent who is not a doctor or a scientist to go back to their clinician and be like, I like this drug, but how about instead of a straight shot, we go for a cocktail where I get half of this and some of that? Like, how do we have that discussion, and which slide or poster of yours could we use to inform that discussion? Like, where is the chart that shows that most kids are on multiple drugs as opposed to a monotherapy?
Yeah, and that specific like comparative effectiveness of combinations of meds is something that I haven't included here. We've looked a little bit. It's harder because obviously the numbers go down too, because to find people, there's a lot of unique anti-seizure medications, and then when you factor in all the possible combinations, you get many more options. But in terms of data, there's not much. In terms of like prescribing philosophy, if you can get away with one med, that's always better. Goal should always be no side effects, no seizures. It's not always an attainable goal, but that should always be the goal. And then if med's effective and side effects are limiting, you can always back off on the dose and add another one. That's what I tend to do. But it's always hard with different people prescribing. I'm not going to tell someone else's doctor what to do. I can always.
No, I know. I'm putting you in a really hard spot, and I apologize, but I'd rather you were in that spot than me, and that's what happens, right? Parents call me exhausted at the end of the day and say, it's not working, what do I do? So I appreciate you indulging my question. And while your deck literally brought me to tears, it'd be amazing if you could visually represent on one slide what percent of Syngapians by age are on a mono versus a combo therapy.
Yeah, no, we
and
can
then what combos are popping, because I do, that is the reality our kids are in. And I just want to echo one thing you said, is back off on the first drug and add a second one. As someone in a front row seat to a lot of these, I see a lot of adding the second, but I don't see a lot of backing off on the first. And our kids end up on a lot of drugs, and there's the toxicity and the side effects don't get as managed as aggressively as the seizures, and I think that leads to a lot of these behaviors. But this is now I'm really getting into deep waters. Missense, bus.
Right. So most of the variants in our population that we've looked at with our data and Citizen are protein truncating variants. We don't have a large enough number of missense and not a large enough number of like recurrent missense where many people have the same change to really get a sense of, are there unique subgroups based on like particular missense variants? There may well be that we just don't know yet, because in other genetic conditions, that is a common finding, that there's certain variants that have unique clinical phenotypes. We just haven't been able to identify it yet in SYNGAP. And there are a lot of VUSs, and hopefully, as we have more patients reported in the literature and more extensive testing, a lot of these will either be determined to be pathogenic or benign and cut down on some of the VUSs. But it's always an ongoing process.
All right. Other family questions, text me, call me, message me before I open up to the non-families. Ashish has questions about long read sequencing. I don't know who Ashish is, but I think he's a geneticist. They're at the top of the Q&A if you want to take those quickly.
Let me just end the slide so I can see the Q&A.
I'm gonna stop sharing your screen.
Yeah. Oh wait, that's what I have to do. I have to stop sharing. Where's my mouse?
It's just always risky to share a screen.
Okay. Open the questionnaire. Oh, there's chat and a Q&A. Okay.
Ignore the chat.
Do you think long read sequencing could reveal further insights into genotype phenotype associations? I mean, so as everyone on the call, people probably aren't all familiar with long read sequencing, where you use, it's basically just technologies to like sequence longer, kind of essentially what it is, but longer stretches of DNA at a time. I don't know that it would, because we already, at this point, we already have we have a problem where we know what the change is, and we don't have a good sense of genotype and phenotype. I think what would help the best is more patients, like identifying more Syngapians, getting clinical detailed information on them, and understanding and knowing what their variant is, and then we can start to detect patterns. But it's hard to do that when you only have like 1 or 2 people with a given missense variant. How do we know whether it's just the natural variability of SYNGAP or whether it's actually something specific to that variant?
All right, we're way over time. I just want to read, Yulia didn't want to jump on the call, but you will meet her on Monday, by the way.
Perfect.
And she said, thank you, Dr. McKee. This was fantastic. As scientists, we really appreciate the important research. As SYNGAP parents, it gives us a glimpse of hope, which means a world. Thank you. I couldn't have said it better. So with that, really loved this presentation. And thank you. We'll see you Monday.
Yeah, thank you so much for having me, and I'm happy to take any other questions offline.